Welcome to today's webinar. Thank you so much for everyone who is joining. Today we have a really exciting webinar about understanding PMS, premenstrual syndromes and PMDD, and we're joined with the wonderful Dr. Anna Cantlay, who is the head of medical here at Evelyn Health. Anna has dedicated her career to empowering women across all phases of life, with particular focus on improving menopause care and supporting those with PMDD. So I'm super excited to listen to this webinar today. If you do have any questions throughout the webinar, we have a Q&A box at the bottom, or you can pop them in the chat, and we'll do a Q&A session at the end to answer all your questions. So I will let you introduce yourself, Anna, and start the webinar. Thank you so much.
Oh, well, thank you for that introduction. Hello, everyone. It's really a real pleasure to be here. And thank you so much for joining us. Very conscious it's December. We're all extremely busy. If you're feeling like me, you're probably a little bit burnt out already. So to make the time and commitment to attend our webinar, we very much appreciate. We are going to be, as Imi said, discussing as much as we can within the time that I've been allocated around premenstrual syndromes, PMS symptoms, and PMDD. And we'll be going back to basics with some biology. We'll be trying to understand as much as we can around some of the causes of premenstrual syndromes, but also what treatment options are available. And I'm just going to move my slides on. Imogen's already done a very nice introduction, but just to say hello again, I'm Dr. Anna Cantlay. I'm a private and NHS GP by trade, but my specialist area of interest is women's health and in particular hormonal health. So I'm a registered menopause specialist with the British Menopause Society, and I run a women's health hub for my local primary care network within the NHS. And we support women with menopause and PMDD. I also run a private clinic. I'm a clinical advisor for the PMDD project, and I'm proud to have joined the team at Evelyn Health to support them as their head of medical. So I've been ambitious, and we are going to try and do as much as we can. So we'll start by just recapping what our female sex hormones are. We'll talk about the menstrual cycle and what's happening across the different phases of the menstrual cycle. We'll discuss the definitions of premenstrual syndromes, the different subtypes, premenstrual dysphoric disorder, PMDD, and really try and do a bit of a deep dive into the neurobiology and what we understand of the underlying mechanisms for hormonal sensitivity. We'll talk about what you can do in terms of lifestyle and nutritional support to support your female health and your female hormones. And we'll do an overview of the medical treatment options that you might be discussing with your GP or healthcare provider. So let's first talk about the female hormones in the body. It's not just about reproduction. Certainly when I was at medical school and we were learning about estrogen, progesterone and testosterone, the main emphasis was around their role on the reproductive health and the menstrual cycle, but their roles are far, far broader than that. And so we'll just spend some time going over those. So estrogen, probably the most well-known female hormone. It's made in our ovaries. It's also actually made in body fat and in our adrenal glands that sit on top of the kidneys. It does have very important roles in reproduction and in menstrual health. So it is important in the development of female sexual characteristics, for example, breast development. It controls most of the menstrual cycle, especially in the first half. And it helps the uterus lining to grow and to prepare for a possible pregnancy. But its reach is far greater than that. So it has so many important roles in the body. It really is a key regulator for so many different bodily processes. It plays a really important role in keeping our musculoskeletal health strong, so our bones and our muscles and strength and recovery. It's really important for heart health, our cardiovascular health. Estrogen is cardioprotective. It has an anti-inflammatory effect in our blood vessels. It can help support and lower blood pressure, and certainly offers us a degree of cardiac protection in those years before menopause. It also plays an important role in helping to with insulin resistance and in keeping our cholesterol levels healthy. It plays such an important role in the brain. I think we're still really understanding and developing our understanding of how important it is in the female brain, but it supports mood, energy, and brain function. It's important for things like memory and brain energy. And our skin is also very sensitive to estrogen fluctuation. So skin health, collagen production, skin elasticity, all very sensitive to estrogen. Progesterone, again, also made in the ovaries after ovulation in the second half of the menstrual cycle. We also secrete it from the placenta during pregnancy, and small amounts get made in those adrenal glands. From the menstrual cycle point of view, progesterone prepares the uterus lining so that a fertilized egg can implant, and then it helps to maintain pregnancy if pregnancy occurs. It works with estrogen to regulate your periods, and if pregnancy doesn't occur, then the levels will drop and the uterus lining breaks down, so your period then starts. But again, has lots of other roles in the body, particularly its interaction with a receptor in the brain called the GABA receptor. And this can, for many, can have a calming and anti-anxiety effect. We'll talk about how that's different in women with, in individuals with PMDD. But it can help to promote a sort of sedative and calming effect, so it can help with sleep. It also has an important role to play in bone health. And also body temperature. So we know that body temperature rises after ovulation, and that's to do with progesterone rises, and often why we might feel a bit hot and bothered as we come up towards those 1 to 2 weeks before our period. Testosterone is not just a male hormone. We also produce it in our ovaries and our adrenal glands, and it's a really important physiological hormone for women. It's known for supporting sex drive and libido in both men and women, and also having a role to play in puberty changes. But it, again, has lots of other roles in the body. So muscle mass and strength, bone health, energy levels, motivation and mood, fat distribution, these are all responsive to testosterone. So what about the menstrual cycle? If I look back to my menstrual cycle education at school, it was really around the bleed, the menstruation. So it was about tampons and sanitary pads. And no one really sat down and explained the different hormone changes that were happening at different parts of the menstrual cycle and how that might make me feel as a young woman. So I think we have a long way to go in education in schools and in really empowering young women and people to really understand what's going on with their menstrual cycles. I was at a talk recently where a brilliant physiologist called Alice Smith did a analogy to the seasons with our menstrual cycle, and I'm going to sort of use that analogy today because I think it's quite beautiful. And actually, if we think about how we've previously and historically thought about our menstrual cycle, it has been much more attuned to nature. You know, we are part of nature as human beings, and you might have heard about the menstrual cycle being related to the phases of the moon. So I think the seasons is quite a nice way to picture what's going on in your body. So let's first start with the first day of the menstrual cycle, which is the bleed, menstruation. And this is your winter, okay? So during this time, the uterus is shedding its lining, which is causing bleeding. Hormone levels, estrogen and progesterone are low. You might feel, and everyone is different, but you might feel low in energy. You might feel more tired or emotional. You might crave rest and warmth and comfort and have a desire to withdraw away from people, to be a bit more introvert. And you might have other physical symptoms, cramps, bloating, or backache for some. So why winter? Well, it's a time when everything slows down. Your body is resetting, similar to how nature rests in winter. The follicular phase actually starts from the beginning of your period and ends with ovulation. So your late follicular phase is that end of period to ovulation, and this is your spring. So during that time, estrogen is starting to rise again. The ovaries are growing a group of follicles. The brain is stimulating that group of follicles to grow, and one of those will become the dominant egg for ovulation. The uterus lining is starting to rebuild, and your energy might start to slowly increase. thinking might be clearer, you might feel more motivated, you might feel your mood lifting, and you might start to feel more social. So it's this coming out of winter slump, this spring where everything starts to grow and regenerate again. Ovulation, which is around day 14 of a 28-day cycle, this is your summer. So estrogen is at its peak. The ovary releases that egg, and hormones boost fertility and natural attraction signals. So this is when we might feel more confident, with an increased sex drive, more outgoing, more chatty, more social. Our skin might be more glowy. You might feel that you're more creative in terms of work, or able to do more complex tasks and more team working. And you might feel that you feel a bit more stronger during your workouts. So it's your summer, your vibrant, energetic phase, like the peak of summer. And then we move into the luteal phase, which starts after ovulation and ends with the first day of the menstrual period. And this is your autumn. So during this time, progesterone starts to rise and prepares the uterus for a possible pregnancy. And if no pregnancy occurs, it drops again, and then you get your period. Mood may dip. Premenstrual symptoms, often very common. You might feel more sensitive or easily stressed. You may have a desire for quieter activities, bloating, breast tenderness, cravings. This can all be very common as well. And your energy might slow and reduce as you go towards your period. So it's that winding down, a time to go inwards, to slow down and prepare for the next winter. So that's why I think it's quite helpful to think about the analogy of the seasons and our menstrual cycle. So what are premenstrual syndromes? So these are cyclical and predictable patterns of physical, emotional, and behavioral symptoms. These occur after ovulation, so in your luteal phase, and typically 1 to 2 weeks before your period. And then the symptoms will ease when your period comes. And 90% of people who have menstrual cycles will experience a degree of premenstrual symptoms. So they are very common to have a degree of premenstrual symptoms. And what we recognize is that there are lots of different premenstrual disorders. So if I take you through this diagram, this is from the Royal College of Obstetrics and Gynecologists, and it just is quite nice to demonstrate the different subtypes of premenstrual disorders that we can experience in premenstrual symptoms. So the one on the left is what we've just discussed there. So the mild PMS symptoms that the majority of us experience to some extent in those 1 to 2 weeks before our period, that are then go away by the onset of your bleed or a few days into that bleed. Premenstrual dysphoric disorder is something we'll talk about in much more detail, but this is a much more severe pattern of symptoms. It's a cyclical, hormonally driven mood disorder. And here, the physical and psychological symptoms are extremely intense and severe. And again, they come in the luteal phase, are relieved by the onset of your bleed, and you have to have around a week, a month where you feel completely well. And what steps it apart from PMS is its impact on your ability to function and your ability to live your day-to-day life. And we'll talk about that in more detail shortly. Premenstrual exacerbation is where perhaps you already have a mental health diagnosis or a physical diagnosis. So let's say, for example, bipolar or anxiety or even ADHD, and you're getting an intensification of those symptoms in your luteal phase. So you become even more dysregulated. But the key is that when your period comes, you're not then symptom-free. You return back to the baseline of your existing mood or physical condition. So that's premenstrual exacerbation. A lot of the talk around PMDD is around it getting better with a bleed, but you might not have a bleed if, for example, you have a Mirena coilin, which thins the lining of the womb, or let's say you've had a hysterectomy, but your ovaries are still remaining. You're still going to have a cyclical pattern from that cyclical cycle with the ovaries, but you won't be having that physical bleed. And so that's just something also to be aware of. The second from the right there is around progestogen-induced premenstrual disorder. And this is really speaking to the recognition that progestogens, in particular progestins, which are synthetic progestogen hormones, can, in some women that are hormonally sensitive and individuals that are hormonally sensitive, can precipitate PMDD symptoms. So sometimes you can get side effects, for example, contraceptives, from that particular progestin. So that's also something to bear in mind. And then if you are suffering with your mental well-being and you're not seeing a predictable cyclical pattern, then it's unlikely that this is hormonally driven, and that there may be an underlying psychological disorder instead that needs to be addressed separately. So what is premenstrual dysphoric disorder, which we've already touched on? So I think this is a really fascinating diagnosis because it sits in this intersection between gynecology and psychiatry, and it often needs to be managed by a multidisciplinary team. It is a severe PMS-like condition, but it's a psychiatric condition in its own right. And this is marked by significant psychological and physical symptoms. The criteria is the DSM-5 criteria is taken from the American Psychiatric Association, which is relatively prescriptive. There are other slightly more inclusive criteria looking at different organizations like the WHO, for example. But this criteria says that you need to have 5 out of 11 different symptoms, one of which needs to be a core mood symptom. These need to present in your luteal phase, and they need to have been relieved by the onset of your bleed or a few days into your bleed, or at least the end of that bleed. And they cause significant distress or functional impairments. So whether that's your ability to work, your relationships, your family, your friendships, or even just get out of bed and do day-to-day activities or self-care, it causes a significant functional impairment. And what's important to understand is that this isn't a hormone imbalance. So if I tested your hormones in the luteal phase, we would expect them to be relevant for that phase of the cycle. What we're seeing is that this is more a altered hormonal sensitivity in the brain. So it really stems in neurobiology. And that brings me on to my next slide, which is really trying to summarize what we understand about the causes of PMDD. And I'll be very honest with you, we need a lot more research to really develop this understanding. A lot of our understanding is still emerging. A lot of the research that we have is flawed. It might not have enough women in it. It's underpowered. So we have a long way to go to really developing our understanding of this. But let me summarize what we do know so far, or what we believe may be contributing. Some of this might feel quite medical, so I'll try and avoid medical jargon where I can, but I do think understanding the detail is important in empowering yourself with that knowledge about what's going on. So serotonin. Serotonin is our mood messenger. Estrogen normally boosts serotonin, and serotonin is our sort of happy hormone. It can help with mood, calmness, and emotional stability. During the luteal phase, estrogen drops, and that naturally reduces serotonin activity for everyone, whether or not you've got PMDD. For people with PMDD, this drop hits much harder. So there's a few reasons why we believe this happens. A transporter in the brain called a serotonin transporter may be too active, so it's clearing away serotonin way too quickly. Or the brain's autoreceptors may be overly sensitive. These sit on what we call the presynapse, and these can tell the neurons to release less serotonin. And so the end result is that serotonin levels in the brain fall too sharply, and this can lead to mood crashes, irritability, and emotional sensitivity. The GABA receptor and the GABA system is the brain's calming circuit. So that progesterone that we're seeing rising in our mid-luteal phase, this is normally broken down to allopregnanolone, a chemical that typically has a calming effect by working on GABA-A receptors, one of the GABA subtypes. Most people, this is soothing and has an anti-anxiety effect, can help with sleep, but we have a paradoxical effect seemingly in PMDD. And that GABA receptor responds differently or not as strongly to that progesterone and its metabolites. And this might be due to genetics and changes in the subtype of the GABA receptor. It might be due to external environmental factors. We're still sort of developing our understanding of that. But what that means is that instead of feeling calm, the normal progesterone rise leads to us feeling much more unstable, anxious, and overstimulated. And the brain's amygdala, which is the emotional response center in the brain, fires up. It feels that you're under attack. So you don't get the calming system calming, and it becomes a lot less predictable, leading to these mood symptoms. So there is data that suggests that neuroinflammation, so brain inflammation and stress, also play a role in PMDD. So around the luteal phase, the hormone shifts that we see can actually increase inflammatory signals within the brain. And in PMDD, there is research suggesting that the inflammation tends to be higher and more easily triggered. Stress is very inflammatory, and poor sleep can also make this worse. And so consequently, we get this sort of overactivation of the brain stress system called the HPA axis, the hypothalamic pituitary adrenal axis. And the mood can become worse. We can also perhaps feel more pain and more tension and more fatigue. So we're much more sensitive to stress, pain, and emotional triggers. PMDD, interestingly, often runs in families, suggesting that there may be a genetic vulnerability. So it may be that there are genes that affect serotonin signaling, GABA sensitivity, and the stress system that behave differently. There has been research that's shown that there's a genetic variation in something called the ESR1 gene, and this is responsible for encoding the estrogen receptor. So it alters how our brain is able to respond to normal estrogen levels. And this can alter serotonin signaling, stress pathways, and emotional regulation as well. On top of that, epigenetic changes, where life experiences and environmental factors can switch genes on and off, can also further increase the sensitivity. So people's brains are simply wired to react more strongly to hormonal changes. A history of trauma or long-term stress can sensitize the brain's stress and emotional systems. And it's not uncommon for trauma to be very prevalent in the histories of the patients that I see in my clinics with PMDD. We know that chronic stress and big stress events like traumatic events can alter serotonin and GABA function. They can heighten inflammation and increase emotional reactivity. And some studies have suggested that up to 61% of individuals with PMDD report past trauma, suggesting that it is a major vulnerability factor. So old stress reshapes the brain, it leaves an echo on the brain, and it therefore reduces our resilience to these hormonal fluctuations. So how can we manage symptoms? So what I'm going to try and aim to do is talk about how lifestyle and nutrition can help. We'll talk about supplements, including those that are included within Evelyn. And I'll talk to you about the medical management that your healthcare provider might be talking you through. And that's typically for more moderate to severe symptoms. We really understand that nutrition is so important for all different parts of health, but particularly for hormonal health. And we should be aiming to eat nutritious food across our cycle, so fueling our body in every phase of the cycle. Now, I'm not a nutritionist, so I'll just caveat this slide with that, but I will talk to you about my understanding of the importance of particular food ingredients like fiber. I don't know if you feel the same, but fiber seems to be everywhere on social media now. It seems to be the new protein. And I'm quite glad about that because fiber is really exciting and it has such big health prevention and health benefits effects in the body. Dietary fiber is part of plant-based foods that your body can't fully digest. And so soluble fiber helps to feed good bacteria in your gut that helps you to digest and eliminate waste efficiently. And it can help to support healthy hormone metabolism. The gut microbiome, in particular, a group of that gut microbiome called the estroblome help process and remove estrogen from the body and recycle it back into the bloodstream. And so when the gut is healthy, extra estrogen is broken down properly, hormone levels stay steady, and mood swings, breast tenderness, bloating, and irritability can be reduced. So it can be really helpful to support healthy hormone metabolism. In addition to that, fiber helps to keep blood sugar steady. So fiber slows the absorption of sugar into the bloodstream and can help prevent big glucose spikes and crashes. And that can help protect hormonal health in several important ways. So when when blood sugar spikes, insulin shoots up, and this is a hormone that's secreted from our pancreas. Inflammation can then increase. Your HPA, your stress axis, gets activated, and we can get more anxiety, irritability, and mood liability, so up and down with our mood. But also hormone signals to the ovaries can get disrupted. Ovulation might be impacted. Progesterone levels might become more unstable, and we can see a knock-on effect to premenstrual symptoms. So unstable blood sugar definitely contributes to more unstable female hormones and unstable mood. Moving back to that gut microbiome, so let's just touch on the gut-brain axis and how that can help regulate mood, stress, and hormones. So your gut and your brain are constantly talking to each other through nerves, through hormones, through chemicals, and your gut microbes help produce and regulate serotonin and GABA, the same neurotransmitters that we know are involved in PMDD. And actually, your gut can produce up to 90% of serotonin, that happy hormone. So a healthy microbiome is supporting a calmer mood and stress tolerance and reducing anxiety. But when you have gut dysbiosis, when that gut balance is out of whack, that can increase more inflammation and affect these important chemicals in the brain, therefore potentially worsening symptoms. So let's talk about what your gut bugs like to eat. That soluble fiber, so thinking about plant-rich diet, oats, beans, lentils, fruits, vegetables. This is all sort of prebiotic fiber, so that feeds the gut bugs. But also think about probiotic foods, so foods that perhaps already have live cultures, so probiotic yogurts, for example, but fermented foods, sauerkraut, kefir, kimchi. These are also really beneficial for your gut health. It goes without saying that unhelpful practices like drinking excessive amounts of alcohol or lots of caffeine, these are both psychoactive substances, are going to further exacerbate symptoms. So it's really worth reviewing and reducing down what we're having from an intake of caffeine and alcohol. Smoking, obviously, if you're smoking, please stop smoking. That's not going to be contributing at all, helping at all. And reducing ultra-processed foods in the diet when we're thinking about an anti-inflammatory diet. And thinking as well specifically for liver support. So your liver plays a really important role in that breaking down and deactivating of your hormones once they've done their job, but also helping to clear excess estrogen and also making a protein called sex hormone binding globulin that can help to regulate hormones by binding to them. And specific foods for liver are your cruciferous vegetables, so cauliflower, broccoli, citrus fruits, also very helpful, but your alliums, so onions and leeks as well. So what about vitamins and minerals? So these can be used in addition to a healthy diet to support your hormonal health. I think the important thing with the umbrella of supplements is that it is what it says on the tin. It's supplementary to existing lifestyle habits and supplementary to treatments that you might be talking about with your GP or your healthcare provider. And we still have a long way to go with the quality of research around the vitamins and minerals that can help with hormonal health. But what's really great about Evelyn is that they really are very diligent at looking at the quality of the evidence, at really trying to use therapeutic doses where we have that information and using the best in class that we have from the data available. So vitamin B6, really important one when we're thinking about hormonal health. It can help support the production of serotonin, dopamine, and GABA. It can help with mood. It can help with stress and sleep. It also aids hormone metabolism, which can help ease symptoms like breast tenderness and bloating. You do need to be careful about dosing, so you can get toxicity to your nervous system if you have regular high doses. And the Department of Health suggests 10 milligrams daily, and certainly no more than 50 milligrams from pharmacy prescriptions. Evelyn has 45, and it's given for half of the month in the luteal phase, so it's within that safe dosing range. Magnesium, again, supports serotonin function. It can activate that GABA receptor, helping to with that calming effect and reducing irritability before your period. And Evelyn's formula combines magnesium citrate and biglycinate for optimal absorption and for a gentle impact on digestion, because some preparations can sometimes be irritant on the digestion. Calcium, another one, really important in supporting hormone responsive tissues. It has a key role in the release of serotonin, dopamine, and other neurochemicals, and it can help the body adapt to hormonal changes across the menstrual cycle. It's also been shown to have a role in reducing menstrual cramps, and we should look to think about what calcium we're having from our diet and also from supplements, aiming in the region of around 1,000 to 1,200 milligrams daily. Most of us in the UK should be supplementing with vitamin D this time of year. We don't get enough from sunlight between the months of October and April. And for those with certain health conditions, it is helpful to think about vitamin D supplementation daily. And vitamin D really helpful when we're thinking about mood and when we're thinking about PMS symptoms. So we know that it can support serotonin and calcium balance and help to improve mood. It also has anti-inflammatory effects, helping to lower prostaglandins and other inflammatory chemicals, and that can help to ease cramps and tension before your period. Omega-3 fatty acids like DHEA and EPA, these are anti-inflammatory. They can also help with that neurotransmitter signaling. They can help support serotonin balance and steadier hormonal fluctuations across the cycle. Similarly, the gamma-linoloic acid, which is a omega-6 fatty acid, this is particularly helpful for things like hormonal breast pain and hormonally related tissue sensitivity. It's quite normal for us to have cravings in our luteal phase, and that's in part to do with the rise in body temperature that can increase our nutrient needs, our metabolic rate. And so chromium can help when we are having food to steady and support that blood sugar regulation, and that can help to reduce cravings and energy crashes and mood swings in the luteal phase. Agnus castus or chasteberry, this has been researched quite extensively for supporting PMS, and this lowers prolactin levels and can have a knock-on effect to things like dopamine, and that can help reduce PMS symptoms, particularly things like breast tenderness, bloating before your period. And saffron, some really exciting research coming out from saffron at the moment. Its active compounds, crocin and safranol, increase serotonin by inhibiting its reuptake in the brain, and there have been some small studies looking at saffron in randomized control trials against things like fluoxetine, an antidepressant, and have shown exciting results in terms of comparison. We still need a lot more research, but 30 milligrams a day is what the research seems to be suggesting is a good dose. So when you experience mild to moderate symptoms, we know that you're likely to need a little bit more, moderate to severe symptoms, you're likely to need a little bit more support. And that's often where I come in as a healthcare provider. And really there are two broad arms to treatment: psychological treatments and cycle suppressive treatments. So if we look on the left, first of all, so your psychological symptoms, we know that things like cognitive behavioral therapy, sometimes couple therapy, or trauma-based therapies like EMDR, if there is a history of trauma, can be very helpful in helping with those thought processes and in reducing mood symptoms. Antidepressants are also an evidence-based treatment. And interestingly, these can be given just in the luteal phase, so after ovulation and or continuously. They're continuous, there's possibly slight superiority or better improvement with continuous dosing, but it typically is the SSRI group, the selective serotonin reuptake inhibitor group. And really what this is doing is meeting that need where we know that we've got changes that happen to serotonin levels, but also actual changes in the serotonin system in the brains of individuals with PMDD. Typically, lower doses can be effective, and typically they work more quickly than in individuals who are using them for other mood disorders like depression or anxiety. So they are a valuable option. We always talk through, patient preference, and we talk through possible side effect profile, but they can be a really valuable option. Cycle suppressive treatments there are a few different options within this. So probably the ones that are more commonly offered include your combined oral contraceptive pills. And what this is doing is it's stopping you from ovulating, and so you're not having that luteal phase. And typically with these, you're running them back to back, so you're not having a pill-free break. So you'd run the active pills back to back, either continuously or tricycling, so for 3 months, then having a short break, then starting again. The challenge we have with the combined pills is that, so not all pills are the same, but combined pills contain synthetic hormones. There are a few that might contain one body similar and one synthetic, but the majority of them, or all of them, have at least one synthetic hormone. And for individuals that are already hormone sensitive, those synthetic hormones can sometimes further exacerbate symptoms. So it can be a little bit unpredictable about how you in particular are going to tolerate that pill. We do have better evidence for certain groups of pills in terms of treating PMDD and PMS symptoms. And typically the one that's recommended as first line is Evelyn. Evelyn contains a progestin called drospirenone, and this has anti-androgenic and anti-mineralocorticoid properties that could be helpful for both mood and physical symptoms in PMDD. But I think it's really important for your healthcare provider to understand what you've been on before, what your prior experience has been, whether it's worth trying these again, changing the pill type, and seeing how you go. And typically we would review things after 3 months to see where response had been. If that isn't the route that you wish to go down, we can actually use hormonal replacement therapy, which is a treatment used for menopause, off license or off label for the treatment of PMDD. And here we would use either a gel or a patch at doses to cycle suppress, so to stop ovulation, and then we'd use a body identical progestin such as Nutrigestin for 2 weeks of the month, or use it alongside something like the Mirena coil. For very severe and refractory symptoms, we have a conversation about medical or surgical menopause. And this is where we give a treatment called a GnRH analog. And this can either be given through injection or through a nasal spray. And that completely shuts the brain's stimulating hormones off. So your brain is not telling the ovaries to ovulate. So it induces a medical menopause. Now, we can't use that by itself, because if we did that, we'd replace your PMDD with menopausal symptoms, but also there are long-term health implications of having your hormones low, in particular bone and heart health. So we do have to add back on some hormonal replacement therapy on top of that. And for some individuals where none of these treatments have worked, they will often be referred to a gynecologist and will have a chat about whether it's appropriate to actually have a surgical menopause where the ovaries and often the womb are removed to completely eliminate any cyclical activity. Just to share this here, Evelyn, to all of those attending today, have an offer for you. And we'll now go on to some questions. Hopefully I've left enough time, 20 minutes.
Yes, you have left enough time. Thank you so much for that. That was so insightful. I'm just going to go into the question boxes and go through them. Okay. So someone has said, "Hey Anna, thanks so much for the seminar. As a woman of colour, I'm aware that many conditions affecting women have been under-researched in non-white populations. In PMDD specifically, do you know current diagnostic criteria and treatment pathways treatment pathways reflect the experiences of women in colour and brown women, and what should be mindful of when navigating care in the absence of robust data.
This is so true. So we even more so true when we look at ethnic minorities. And so it's yes, the short answer is no, there has not been enough data looking at women of colour, and we need a lot more data to understand how symptoms might change, and whether there are any treatment options that need to be altered based on things like other genetic factors. So at the moment, we don't have that guidance. So I think we have to just look at the individual in front of us. Things that I find helpful are so all of, you know, in the NHS, I don't get as long, but in my private sector, I'm able to spend an hour with patient. And so really understanding that individual in front of me in terms of cultural and societal nuances, prior experience of things like contraception and treatments that they've tried. And so we try and make it personalized in that way. But no, we do need the research to inform both the symptom presentation that might be different and what treatments might be different. We don't have that at the moment.
Thank you. She's also asked, I want to better understand my own hormonal patterns. So what is the most clinically useful way to approach hormone testing with my GP? Moreover, how would you recommend I frame this conversation with my GP to avoid being dismissed or told that hormones are normal?
So the most empowering thing that you can do is to use either a written diary or a symptom diary through one of the apps to cycle track. This will really help you to get that further understanding of what you feel across each individual bit of the cycle, because not everyone is the same. So everyone's slightly different in terms of their symptoms across the menstrual cycle. But if you're able to demonstrate, and this is what's needed for PMDD diagnosis, if you're able to demonstrate at least across 2 cycles or 3 cycles a consistent pattern, then that demonstrates that actually there's something hormonally driving that. Similarly, if you're not suffering with PMDD, but you're worried about hormone imbalances like PCOS, for example, generating that data around your menstrual cycles and other symptoms that you might be experiencing, whether it's unwanted body hair or facial hair, is really important. I think speaking to your GP in the NHS, you've got sort of a 10 to 15-minute appointment. So how can you make the most of that appointment? The things that I would say is come with as much prep as possible. So come with your symptom diaries. If you've got a particular guideline that you'd like to discuss, bring it with you. If you're worried about missing things, bring a friend, bring an advocate with you if you feel that you're not going to be able to sort of get all of that information across. Ask for a double appointment. We do give double appointments out if there are more than one thing, or if it's a meaty discussion. It might mean that it's longer to wait for that appointment, but that is also an option. And then if you're not getting that answer from your healthcare provider, or you feel that you're being gaslit or there's medical gaslighting, do ask for a second opinion. In most practices, you will have a GP that is more women's health specialist, so ask to see them. If you're not getting that answer there, ask to be referred. But the more information that you can come with, I think the more you're going to get out of that consultation.
Thank you. Somebody has said, thanks, Anna. I'm perimenopausal 51 and take Evelyn. I also take HRT, but never know if this is helpful or counterintuitive. Sorry, can't speak. Adding hormones back, I'm sensitive too. What is your advice for perimenopausal women?
So I think this actually allows us to talk about something that perhaps isn't often talked about. But we have pockets of vulnerability in terms of our hormones in our lives. So premenstrually, postnatally, and in perimenopause. And if you are someone that suffered with PMDD, you are more vulnerable to get postnatal depression. You are more vulnerable to have a difficult perimenopause. And so I think it's important to sort of talk about that, prepare for it. HRT, these are body identical hormones, so they have the same molecular structure to your own natural hormones. So often they are better tolerated than the synthetic hormones in, say, the contraceptive pills. And for that reason, they are licensed in treating menopausal symptoms as well. So certainly around perimenopause, PMS symptoms might become more severe. And you could certainly look to address both PMS and other perimenopausal symptoms with HRT. The caveat I would say is that if your pattern of symptoms is still more cyclical, it may benefit you to go on a higher dose of HRT. So the sort of standard cycle suppressing dose is 100 microgram patch or 4 pumps of gel, and see if that helps to level out from stopping out your sort of random ovulations that will be happening in perimenopause. There are sensitivities, of course, even to body identical HRT. These are a group of individuals who are hormonally sensitive. And so, for example, navigating things like progesterone intolerance, which is very common, can be tricky. But there are things that we can do. So, for example, you might take your progesterone vaginally, and that can sometimes help reduce the amount that's going into the bloodstream. So there are little tweaks that your healthcare professional can do to work through that progesterone intolerance with you. But anyone that has a womb who's taking estrogen in the form of HRT must always have a progesterone on board. Otherwise, you get thickening of the lining of the womb, which is dangerous. So yes, it is an appropriate thing to do, but you have to tweak it based on your experience and how you're tolerating it.
Thank you. We've had another question. So somebody has said, my daughter suffers from PMDD and has also been diagnosed with PCOS. Do you have any advice regarding PCOS in relation to PMDD? She has irregular periods.
Yeah, so there's definitely a correlation between the two in terms of because with PCOS you have abnormal signaling, so particularly LH pulses within the brain, luteinizing hormone. There's an abnormal signaling from that, and that can further drive hormonal sensitivities. It can also become more tricky because you might not be consistently ovulating, and so being able to sort of put a toolkit in place around when you think you're in your luteal phase is really tricky because you just don't always have a predictable bleed pattern. So yes, there's definitely a correlation between the two, and they need to be addressed as two individual conditions because there's a different management pathway for PCOS, but also thinking about the two together. So for example, you can use the combined pill, for example, to regulate ovulation or regulate, your bleed in PCOS, and you could choose to use something like Evelyn that has been evidenced for PMDD, but also has anti-androgen properties, which can be helpful for PCOS in terms of that facial hair or unwanted body hair. But they do have different guidelines, and there's different considerations for both, so they have to be managed reflective of that, but also everything, they don't happen in isolation. Our female hormones are all talking to each other. So yes.
Thank you. Someone else has said, thank you, Anna. I've been struggling to get a diagnosis for some time now, constantly getting dismissed. What can I do to advocate myself? I've shown my cycle for 6 months and still being told it's not PMDD. I'm certain that it is. I've been put on antidepressants, but I don't want to be on them anymore. And the only other option I've been given is the pill.
So I'd challenge to ask what is it that they feel isn't meeting the criteria. So if you are showing across 2 or 3 cycles a cyclical pattern in the luteal phase of mood and physical symptoms, and again you can have a look at that DSM-5 criteria, it's available online, that's going away with your period, and then you feel well for a week, a month, typically after your period to ovulation, and you're demonstrating that that's impacting your quality of life, then you would meet the diagnostic criteria. So I think having that out in front of you and saying which bit of this isn't the criteria is helpful. If you feel that you are and I think we have to sometimes remember that yes, PMDD it's important to get a diagnosis, but some might fall short of that diagnosis. but still have really severe PMS. And we still need to manage that with the same approach. So if you feel that you're not getting the benefit from the antidepressant and you're hesitant about the pill for whatever reason, and you would like to explore other options, including hormonal replacement therapy, for example, and your GP doesn't feel confident to do that, then they should refer you to a gynecologist. And you are within your rights to ask for that. And there will be gynecologists that are more specialists in PMS and PMDD. Sadly, we don't have that many what we call tertiary centres in the UK, which particularly specialise in this. There's a couple in London that will accept out of area referrals, but you have to go through an individual funding request through your ICB. So it's a bit clunky and it means that access is limited. But there is help available through these tertiary centres, but your GP has to be that advocate for you to get that funding. So yeah, I would challenge, take an advocate, take the criteria, do all your symptom tracking like you're doing, ask them for a reason, or ask to get a second opinion from a different GP at that practice. The other thing is speak to your practice manager. If you feel that you're not getting the right advice, share your concerns with the practice manager, and they'll also then do a review of your history and your case and see whether anything else can be done.
Thank you. We have time for a couple more questions. So if you do have anything, just pop it in the Q&A box. Someone else has asked, in someone who is already taking an SSRI for PMDD, how should I think about using a supplement routine like Evelyn? Specifically, what are the best ways to assess whether the supplement is genuinely contributing to symptom improvement versus changes that might just be due to the SSRI?
That's really difficult because you'd have to, for us to be able to tell whether it was one or the other, you'd have to review it in isolation, and you'd have to, gold standard would be a randomized control example. So you want to try and perhaps not get too caught up in the nuances of that. I think we do know that the ingredients within Evelyn have been specifically researched for their role in supporting PMS and PMDD. So they're likely to add some value in addition to what other treatment that you're on. Unless you were just on one by itself, it would be difficult to say for certain, whether it was that or whether it was your SSRI. But I guess it's more important to focus on a combination of treatment modalities, because as I said, it's not as simple as take this pill, get better. It is very much a grassroots, let's look right down from the bottom of nutrition, lifestyle, how are you managing your nervous system regulation on a daily basis? I think we often prioritize going to the gym or moving our body, but what does it look like in terms of how we manage our nervous system? Are we getting up and we're constantly in fight or flight mode on our phones, into meetings, 3 caffeines down, coffees down, and sat at a desk from 9 to 5? What that's obviously not going to work for your stress levels. And I think particularly in the fast world we live in, we're in a constant stress stimulus environment. So how can you make a commitment to really take the time to invest in nervous system regulation across your day, whether it's mindful breathing or diaphragmatic breathing or meditation? So yeah, it's difficult to know for certain, but I think it does need to be addressed from lots of different facets anyway. And if you're feeling better, that would be the outcome that would, regardless of which bit of that was working for you. It may be cumulative, it may not be, it may just be one bit, but the outcome is the most important bit.
Amazing, thank you. So last question, somebody has asked, is PMDD considered a curable condition, or is it better understood as something that is managed long term? Just interested.
So I think because of all of the factors that can contribute to it, it is generally considered a long-term condition, and that's why it can be considered as a disability, because it's a chronic long-term condition that impacts your ability to function. So whilst you may significantly improve the severity of your symptoms, and you may lessen it from severe to mild, where you can live your life and get on with your life. That sensitivity is likely to remain, whether that's from your genetics or whether it's from prior stress and trauma or environmental factors. That sensitivity is probably primed within your brain. So yes, I do always counsel that it does need to be very much considered as a long-term condition. And because of that, we need to plan for other potential events like pregnancy, like perimenopause, because this sort of susceptibility to being sensitive will remain.
Thank you. Well, thank you so much for running this webinar. It's been amazing. I've definitely learned so much, and I hope everyone who has joined has learned something as well. I'm sure they have. Thank you so much, Anna. This has been incredible. And thank you everyone for joining. Have an amazing rest of your day, amazing weekend, and have a good Christmas.
Happy Christmas, everyone.
Thank you.
Bye.